Welcome to This Week in Family Medicine. This week, we're covering 9 notable papers spanning updated guidance on common chronic conditions, the uncomfortable question of how payment and oversight systems shape our prescribing, and new evidence on delivering care digitally, mobile, and across the hospital-to-community divide. Let's dive in. We start with 3 papers that update how we assess and manage bread-and-butter primary care problems. In Annals of Internal Medicine, Corrado and colleagues present a synopsis of the 2025 Veterans Affairs and Department of Defense Clinical Practice Guideline on adult overweight and obesity, built on a systematic review of evidence through January of this year and graded using standard methodology. The framing matters as much as the recommendations. Obesity is treated explicitly as a chronic, relapsing neurohormonal disease. The working group suggests routine screening in all adults at a body mass index of 25 or above, with a lower threshold of 23 for Asian adults, and asks us to add waist circumference and clinical context to refine risk rather than relying on body mass index alone. Comprehensive lifestyle intervention remains the strongly recommended foundation of care. But here is the practical shift for the clinic. There was insufficient evidence to say pharmacotherapy should be delayed relative to lifestyle intervention, and there is no requirement that patients complete a lifestyle program before you add medication. The guideline also explicitly discourages stopping effective medication in patients who are doing well, because weight regain follows. New recommendations cover the GLP-1 receptor agonists, endoscopic therapies, and metabolic and bariatric surgery, all framed around stigma-informed longitudinal care. Alongside that, JAMA carries a review of postural orthostatic tachycardia syndrome from Chung and Raj, a condition estimated to affect somewhere between 1 in 1,000 and 1 in 100 people in the United States, roughly 90% of them female, with peak onset between the ages of 13 and 29. The diagnostic criteria are worth committing to memory. Chronic orthostatic intolerance, with a sustained heart rate rise of at least 30 beats per minute within 10 minutes of standing, 40 beats in adolescence, and, critically, in the absence of orthostatic hypotension. In a survey of nearly 5,000 patients, about 70% reported substantial functional impairment with loss of school or work participation, and the median delay to diagnosis was 2 years. In 30 to 40% of cases, symptoms began within 3 months of an infection, including SARS-CoV-2 Epstein-Barr and influenza. Your job in primary care is to exclude the mimics: thyroid disease, adrenal insufficiency, anemia, dehydration, cardiomyopathy, and drug effects from stimulants or diuretics. Then start with non-pharmacological management: increased fluid and sodium, lower body compression, heat avoidance, and structured supervised aerobic training. Drug therapy, from beta blockers to ivabradine, midodrine, fludrocortisone, and pyridostigmine, is individualized and, the authors are candid, supported by small studies rather than large randomized trials. And rounding out this group, the BMJ publishes a state-of-the-art review of acute hyperkalemia from Rech and colleagues, a reminder that the patients we see most often, those with chronic kidney disease, heart failure, and diabetes, and those on renin-angiotensin-aldosterone blockade, are precisely the ones at risk of malignant arrhythmia, and that practice varies widely because definitions and risk stratification differ across settings. The review updates management in light of the newer potassium-binding agents. The second theme is uncomfortable, and it comes from 2 papers showing that prescribing responds to incentives and observation rather than purely to patients. In the Scandinavian Journal of Primary Health Care, Kraft and colleagues used nationwide Norwegian registry data from 2008 to 2019, covering more than 500,000 patients who switched general practitioner, and applied a difference in differences design comparing those who moved between doctors paid differently. Patients who moved from a salaried general practitioner to a fee-for-service one saw their antibiotic use rise by about 85 defined daily doses per 1,000 patients per month, while those moving the other way, from fee-for-service to salaried, reduced their use by around 21 defined daily doses per 1,000. Same patients, different payment model, different antibiotic exposure, with consultation frequency and patient selection as plausible mediators. The mirror image appears in the BMJ, where Crone and colleagues exploited the essentially arbitrary timing of unannounced Joint Commission accreditation inspections at United States hospitals. Looking at more than 230,000 Medicare admissions among people with no opioid claim in the preceding 90 days, they compared discharge opioid prescribing during inspection weeks with the 3 weeks either side. At teaching hospitals, the odds of a new opioid prescription at discharge were about 19% higher during inspection weeks. At non-teaching hospitals, there was no statistically significant difference. The interpretation the authors offer is that heightened scrutiny of pain management may nudge clinicians towards prescribing. Read together, these two papers make the same point from different angles. Prescribing is not purely clinical, and quality frameworks and payment structures can produce effects nobody intended. Our third theme is service delivery, how care reaches people. PLOS Medicine reports a 3-arm randomized trial from Johnson and colleagues of a digital symptom management program in 825 adults with chronic medical conditions recruited across 13 countries. The program combined video-guided movement, breathwork and meditation with a coping skills curriculum and disease education, delivered either self-directed or with weekly telephone check-ins of up to 15 minutes from trained non-clinicians. Against a waitlist control at 12 weeks, the human-supported arm improved hospital anxiety and depression scale total scores by about 2.9 points, and in exploratory analysis, the self-directed arm improved by about 2.6 points. Crucially, there was no significant difference between the two intervention arms on any outcome. Adding a human did not add measurable benefit, which is encouraging for scalability. Both arms improved fatigue and quality of life, and no intervention-related adverse events occurred. The caveats are real. A waitlist control does not account for nonspecific effects. Most diagnoses were self-reported, follow-up was only 12 weeks, and the sample was predominantly female and highly educated. On the screening side, BMC Primary Care publishes a pilot from Houtenbos and colleagues testing point-of-care analyzers for metabolic syndrome in a mobile examination unit with 50 participants. One device, the Alere analyzer, showed the smallest bias against reference laboratory values for glucose, triglycerides, and high-density lipoprotein. And metabolic syndrome classification did not differ between measurement days, suggesting mobile point-of-care screening is feasible for early detection. Though with 50 participants and only 16 in the test-retest analysis, this is a proof of concept, not a mandate. 2 qualitative papers address the structures around care. In BJGP Open, Body and colleagues interviewed 15 general practitioners and trainees using a mock vignette and think aloud methods and describe a process they call HATCH, Holistic Adjustment to Context After Hospital Discharge. Their finding is that discharge summaries, which give data but withhold the explanation and context behind key hospital decisions, actively obstruct generalist decision-making and create hidden safety risk, even when the general practitioner manages to compensate. And in the Scandinavian Journal of Primary Healthcare, Väisänen and colleagues analyzed 31 Finnish policy documents on primary care service network planning, finding that counties justified closures and centralization by workforce shortage and poor premises rather than finance, and leaned heavily on digital and mobile care as the precondition for withdrawing physical services, while detailed long-term planning was largely absent. If you only have time for one paper this week, make it the 2025 Veterans Affairs and Department of Defense Obesity Guideline Synopsis in Annals of Internal Medicine. It directly answers the sequencing question that comes up in almost every weight consultation: whether patients must earn pharmacotherapy through lifestyle intervention first, and it tells you not to stop what is working. Here are the key takeaways from this week in family medicine. First, you no longer need to require completion of a lifestyle program before starting obesity pharmacotherapy, and effective medication should not be stopped in responders. Second, in a young patient with chronic orthostatic intolerance and a 30-beat heart rate rise on standing without a blood pressure drop, think of postural orthostatic tachycardia syndrome early. The median diagnostic delay is 2 years. Third, Payment models and inspection cycles measurably change prescribing, so build safeguards for antibiotics, and discharge opioids into system design, not just into individual willpower. Fourth, a self-directed digital mental health program worked about as well as one with weekly human check-ins in adults with chronic conditions, which makes low-resource scaling plausible. And fifth, discharge summaries need the reasoning behind hospital decisions, not just the decisions, if generalists are to safely continue care. That's your roundup for This Week in Family Medicine. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And think of one colleague in any specialty who never has time to keep up with the literature. Tell them about Audio Scholar, a free 10-minute weekly for every specialty, to listen to in any podcast app or to read at audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.